Hello, I'm Chappie Conrad. I'm one of the vice chairs of the Department of Orthopedic Surgery and director of the Sarcoma Service at the University of Washington. The Sarcoma Service at the university delivers care to patients with sarcomas within our Cancer Care Alliance, which we call the Seattle Cancer Care Alliance. It includes the fusion of the University of Washington with the Hutchinson Center and the Children's Hospital. I'd like to discuss with you today the treatment of sarcoma patients and some of the advances that we've experienced over the last 10 to 15 years with these patients. A sarcoma is a malignancy of connective tissues. It differs from malignancies of glandular tissues, which are much more common and typically most commonly occur in the lung, prostate, breast tissue, and all the more common malignancies. Sarcomas are much less common but very important because they occur in all age groups. They're large tumors. They've given us a lot of information about the biology of cancer that has implications for the more common types of malignancies, and they're a very treatable type of malignancy. This is a slide of an MRI from a patient with a tumor in their thigh. This is a cross-section through a thigh. This is the normal side. Here's the tumor. It's a large, white-looking image. And these, despite being a relatively large tumor that may originate from muscle or tendon or even bone, it's a tumor that presents with very little pain and only a subtle soft tissue mass. So they're difficult to diagnose early on. And these types of tumors have a type of biology that's similar to other tumors, but their direct cause in many cases is still being investigated. These patients present with a bit of a diagnostic delay. They have very subtle symptoms. When they have a tumor in the soft tissues, like in the muscle tissue, they'll only present with a painless mass. They can have those symptoms initially thinking that they have a muscle strain, and that can occur for up to 3 to 6 months before they have a diagnosis. If they have a tumor in a more difficult location, such as the pelvis, it can take 6 to 12 months before a diagnosis is reached. Early treatment is key in these patients, and distinguishing whether those are high-grade tumors or low-grade tumors can have an important effect on the patient. We have an excellent team of doctors and nursing staff and support staff for sarcomas. We have one dedicated oncologist, Dr. Schutze at the university, and Dr. Hawkins at Children's. We have a dedicated pathologist, Dr. Rubin at the university, a dedicated imaging specialist, Dr. Erie, who pilots our PET scan program, which is a pivotal part of our program, and a large group of orthopedic and general surgeons. One of the things that keeps us together as a unit and a well-organized unit is the fact that we get together 2 or 3 times a week in clinic and in conference. We review all the new patients on a weekly basis in conference with all of us together. And we take care of patients together, both the oncologist and the surgeons together in clinic at our SCCA clinic in Southeast Lake Union. Another thing that distinguishes our service is our comprehensive tumor registry that we have to register the care of all sarcoma patients, which is almost unique, believe it or not, in the cancer world. Many of these tumor registries are hospital-based and many times don't collect enough information to be useful for a specific subtype of patient. We have that kind of dedicated sarcoma tumor registry for all of our patients to assist with patient care and patient education. The big challenge for a sarcoma patient is to distinguish early on whether that patient is at risk for metastasis or a spread of their tumor from the location of where the tumor originally started, such as the leg or the arm or the pelvis, and whether it has a risk of spreading to the lungs, which is typically where it goes through via the bloodstream. That decision traditionally has been made with a biopsy. The biopsy is done usually as a surgical procedure, occasionally as a needle procedure. And that piece of tissue is then looked at very carefully by a pathologist, and a decision is made about whether that tumor is high grade or low grade. And many times difficult decisions have to be made between those two types of categories. A high-grade patient would be at risk to have a metastasis, and their life would be threatened by that tumor because the tumor would spread to their lungs and kill them by that process of tumor growing in the lungs. So a major decision in these patients early on is with the biopsy and whether they need and deserve chemotherapy and whether chemotherapy would be useful. When a pathologist is looking at that biopsy, they have a very difficult task at hand. They do have some additional stains they can use under the microscope, but much of the old information by looking at a tumor under the microscope is being added to today by more sophisticated techniques. This is a slide of a liposarcoma, which is a fatty malignancy on the left, and a sarcoma that's undifferentiated on the right. And while there's a big difference in the number of cells in these two slides, you can imagine that the experts will disagree on what kind of tumor this is and also whether it's a high-grade tumor or a low-grade tumor. And it is a very challenging part of the business that we've improved with better biology. This is part of that better biology. It's a DNA fingerprint, if you will, of the tumor. We have a technique now that will take many of these tumors at one time and do an assessment of their DNA content and what distinguishes that type of tumor based on its DNA content in terms of subtype, in terms of grade, what type of molecular markers there are to distinguish the subtype of that tumor, and also to put these tumors into different sorts of families in terms of the defect, the DNA defect in one particular tumor. These are very important sorts of new DNA fingerprintings that can occasionally help us directly focus treatment on an enzyme or protein deficiency that we can correct with a particular type of drug. So these new cDNA microarray techniques that we try to do on all of our patients will help us not only determine who's at risk, but what kind of treatment they might have and what kind of treatment might be directed in terms of molecular defect. Here's the typical sarcoma in an adult. It's a soft tissue sarcoma. It occurs in the calf. This is an MRI of a calf. Here's the left posterior calf. Here's the right lower extremity. You can see a large tumor here in the upper calf of this patient. It's actually behind the tibia bone here in a very awkward location next to every major artery and nerve in this patient's leg. This patient was given chemotherapy. They had a very good response to chemotherapy. The tumor was then taken out surgically. They were also finished their chemotherapy, received radiation therapy, and is doing extremely well several years down the road with an MRI now that shows basically a normal leg and excellent function. The basic model for treatment in these tumors is still a little bit controversial. There's no controversy that an assessment needs to be made with a biopsy early on in the patients and a decision made about whether chemotherapy should be given at all and whether it should be given early or late. We're big advocates of early chemotherapy in these patients. We monitor them very carefully with repeat MRIs and repeat PET scans. PET scans, in addition to improved biology, are the key to most of the improvements we've made in our patients, in addition to a few new chemotherapy drugs that allow us to treat patients who would previously be unresponsive to chemotherapy. So any one particular patient would come in, have a biopsy, make a decision, yes or no, about chemotherapy, receive chemotherapy the first month, the second month, have more imaging, have a surgical resection, and then receive the rest of their chemotherapy. Let me tell you a little bit about PET scans. A PET scan is a proton emission tomography. It's a fancy scan to evaluate whether a tumor is metabolically active. It involves the imaging of a labeled glucose molecule, for instance, in this particular case. It tells us how fast this particular tumor is eating up glucose and whether they're doing it rapidly or slowly. This is a great example of a large sarcoma. Here we see an MRI in this particular patient. This is the back of the thigh in a patient with a tumor that's almost 20 centimeters or 10 inches in size. This is a large tumor, and it varies tremendously from its north pole to its south pole and in the middle. In this particular case, we did a PET scan prior to the biopsy of this patient, and it shows a very active tumor or a hot spot in the north pole of that tumor. The middle part is mixed. Half of it's very active, half of it's inactive, and the south pole is very inactive in this particular tumor. That enabled us to biopsy this patient in the most active location, and for research investigational purposes, we did 3 biopsies in this patient, all with a needle, so that involved no significant trauma to the patient. And the biopsy from the top showed a very active high-grade tumor. The biopsy in the middle showed a tumor that was sort of mixed grade with intermediate grade pathology. The biopsy from the bottom showed an inactive dead tumor, a tumor for which we had not given chemotherapy. And this is a good example of how a PET scan can help us be more accurate about grading patients with regards to their risk early on and also assessing their response to treatment. So these PET scans don't give a perfect image of the tumor, but they give a very reliable metabolic image of the tumor. And they give us a number that we can quantify, a number anywhere from 1 to 20 that tells us which tumors are really hot and active and need chemotherapy, and which tumors are relatively inactive and don't need chemotherapy. That decision is made up front with a PET scan when we first see the patient, helps us direct the biopsy, helps us make an assessment of what the patient risk is. We repeat a PET scan after their first few cycles of chemotherapy. That helps us make a decision about whether chemotherapy is working or not. And if we have any problems with deciding where to do the biopsy in the patient, a PET scan also helps us with that. It's a very valuable tool today for these patients. Here's a PET scan data. We've got a very fully funded project on PET scans for sarcomas. It's one of the pilot projects for imaging cancer with the NIH. Here's the prediction of a hot PET scan. PET scans in sarcoma patients where the SUV value, the uptake value, is less than 6, shows a higher survival in patients with a PET scan that has a number that's greater than 6. So a patient with a really hot PET scan initially is more at risk to have a worse survival than a patient with a low number early on. If they have a good response to chemotherapy, their prognosis is equally significant. If we image their chemotherapy response on a PET scan and it shows a good response to chemotherapy, that patient will probably do very well. And that's the earliest signal we can get that chemotherapy is working in our patients. A very valuable new advance in the imaging of these patients. We like to have more effective drugs for sarcoma patients. We do have many clinical trials, some of which are in our own hospital, some of which deal with children's protocols that we now apply to young adults, some of which have to do with carefully regulated studies with new drugs through the FDA and through various options in North America for treating patients with new drugs, and other collaborative groups in North America that deal with the treatment of sarcoma patients and new drugs, all very carefully guided protocols, typically referred to as clinical trials. These are crucial in discovering new drugs. It's been a while since we've had really effective new drugs in sarcomas, and we do have some new drugs in the last few years that have proved to be very effective for these patients. Tumor surgery for these patients mostly involves surgery on the soft tissues. Here's an example of a forearm with a small tumor that had a relatively low PET scan early on. We could make the decision to take this tumor out with an operation despite this gaping wound. This is an operation that takes away very few functional muscles and really leaves this patient with a very functional forearm. Here's the bone tumor version of sarcomas, a large bone tumor in the lower femur just above the knee joint. Here's the knee joint here. And this is a malignant tumor. We have to take out the entire 6 to 8 inches of this femur, and we can now replace that with a metallic femur and a total knee replacement. This is the regular total knee plus another 6 to 8 inches of resected femur. These patients do very well with these procedures, and we have an example of that in one of my patients here today. Here's a more difficult pelvic tumor that's almost invisible on a plain X-ray with a huge